And I have some competing interests, I should declare. I have research funding from institution in Czech Republic, not regarding to this project, but I have a consultancy agreement with GE Healthcare regarding intraoperative lung protective ventilation adequacy of anesthesia concept, and also have consultancy agreement with Medicel, which is a Czech distributor of GE device and medicals. So I'm from Czech Republic. I work in hospital in Ústí nad Labem in Děčín. These are two nearby hospitals in the North Bohemian region, and the region is mainly famous for its nature, and maybe you know from the movies the rocks that are surrounding this area. And I work in these hospitals as senior anesthesiologist, and in one of these hospitals as deputy of medical director. So that's my background. This is the hospital, the university hospital in Ústí nad Labem, which I spend most of the time, and where we use the care station insights. Just to know about the background of this hospital, this is a reference center for the whole North Bohemian region, and we do about 20,000 general surgeries per year. We do mainly all specialties except transplantations. So there's quite a big range of surgeries we do, and we try to digitalize all of the data from these surgeries and to compare them. And I will show how we work with this. And first of all, I will talk about postoperative pulmonary complications, which is for me and for our department like the biggest reason for, I would say, like, to do some promo for intraoperative lung protective ventilation, and this should be like a red line that is going through our whole care in anesthesia regarding lung protective ventilation. And which is important for me to mention is that yearly there's about 230 million major operations worldwide, and reported incidence of postoperative pulmonary complications differ from 1% to 23%, but it very depends on the definition that we choose for postoperative pulmonary complications. In different papers, we can see that postoperative pulmonary complications are more common than cardiac complications. We all do care about cardiac complications because we can see the cardiac complications most usually immediately. The thing with postoperative complication is that we, as anesthesiologists, we mainly don't see them when we have the patient in care. We can see the postoperative pulmonary complications 2 weeks after the surgery, or maybe later. So if we applied another definitions of postoperative pulmonary complications, we can have incidence about 60%. And if we are talking about laparoscopy, or about patients that are undergoing laparoscopy or robotic surgery, then the incidence can be up to 80%. And some definitions also include oxygenotherapy for the patients after the surgery in patients that doesn't need the oxygenotherapy before the anesthesia. And if we do apply this definition, then the incidence is very high, and I believe that everybody knows or came across a patient in everyday practice that has oxygenotherapy after the general anesthesia, even though the patient is healthy lung and he shouldn't need oxygenotherapy. So that was the main reason that brought us to these problematics, to postoperative pulmonary complications and lung protective complications, and why we want to get some data on these problematics, and to manage how we can improve the care and maybe lower the incidence from, I would say, 80% in laparoscopy patients. So just to show that there is a connection between postoperative pulmonary complications and intraoperative and mortality and outcome of the patients, there is a very nice paper from Professor Neto, and he showed that for major surgeries, the patients that suffered with with postoperative pulmonary complications, there was significantly higher mortality in these two groups. As you can see, these two groups are for thoracic surgery and for abdominal surgery, for major surgeries, and these two groups suffered with postoperative pulmonary complications. And these two groups up here, these are the groups that didn't have any postoperative pulmonary complications. So there's a clear impact on patients' care if we can lower the incidence of postoperative pulmonary complications. And of course, the question is how we can lower the incidence. We have some data and some papers, I would say very famous papers, that lung protective ventilation can influence the mortality of ARDS patients. The first very famous paper from New England Journal from the Acute Respiratory Distress Syndrome Network, I would say, stated some ground rules or make some foundations for lung protective ventilation. Yes, it is true, this paper was in ARDS patients with respiratory failure. It's a completely different group of patients that we are facing most of the time, because we are facing healthy lung patients that are prepared for the surgery and they are coming at the best moment and they are planned. So yes, we can argue that there might be some difference here, but if we applied these rules that this paper stated, and I must say it was in 2000, so it's now nearly 25 years old paper, so it's nothing new. And if we transfer these rules from these patients, to healthy lung patients at ICU, we see that these patients' outcome was better compared to patients that didn't receive lung protective ventilation. This led in the last 20 years to many papers regarding lung protective ventilation and patients' outcome in general anesthesia. And I would like to highlight this paper from British Journal, from Christopher Young. And I would say it's a guidelines that how should be done lung protective ventilation for surgical patients during general anesthesia. It's a consensus, expert-based consensus, and there are about 20 recommendations how we should do the lung protective ventilation. And most of the recommendations does not differ from this paper. We believe that not all the physicians read the papers, so we developed our internal standard in my clinic, how should be done the lung protective ventilation. So we developed this standard operating procedure, and it should be a mandatory for every physician in our clinic to adhere to this protocol. I will go quickly through the points that we made and then that we would like our physicians are adhere to. We choose breathing volume 8 milliliters per kilo. There was a big debate because from ARDS network the famous number is 6. But if we go through papers that are addressing the problematics of intraoperative lung protective ventilation, we can see that the recommendations range from 6 to 10. So we choose the middle way, which is 8. So that's how we came to 8 milliliters. And it should be ideal body weight, of course. So for making clear how everybody should calculate IBU weight, we add the IBU. And another, for me, a very important recommendation that we can see in all papers is PEEP. From the work that I talked about from ARDS network, everybody knows that there is a tidal volume 6 to 8 recommendation, but there were more than 15 other recommendations that were applied in the study, and they are not that famous, and one of it is the level of PEEP. The level of PEEP in most of the studies is usually between 4 and 8, and we want to test how our physicians applied to our protocol, and we know from our educational sessions that if you have anesthesia machines from different companies, if you set PEEP 4, for example, in some companies it will be lower than actually 4 if you measure it on a separate ventilation simulator. So then we choose like the higher recommended value, 8. because then we know that all of our anesthesia machine will be in range, in real range between 6 and 8. Then another important recommendation for initial setting of the ventilator, because most papers and most data that we have for these problematics are highlighting only initial ventilator setting, because it's very problematic to collect data during your anesthesia minute by minute. So we choose 15, and we used the mechanical power theory for this, that it's not only about tidal volume and PEEP, but it's also about frequency, because we are caring about the total energy that is delivered to the lung in a given time. So that's why 15. And then this is, I would say, a bit controversy to recommend during anesthesia, because there is not some bedside tool how to measure it properly, as is in ICU. But we found that if you want people to adhere to some protocol and to some changes, you should always keep there something that they really knew and they are used to do it. So we leave in our recommendations the driving pressure there, and plateau pressure and high pressure, and it's very well known thresholds that we should not overcome. And what we add there is inspiration pause in volume controlled regimes, which we saw during the anesthesia visit. That is a parameter that is normally not used by anesthesiologists, at least in my country. I must admit that, even though it's not perfect. So we said that all physicians that are using volume control modes, they should set to 30% the inspirational pause. And that was that was the first part of our internal standard, and we have another part of the standard, and it might be a bit controversial in anesthesia. But after some internal debate in my clinic, we came across recruitment maneuvers during general anesthesia, and we decided that even though in the paper from BGA from 2019 from Christopher Young, he stated that one pillar of lung protective ventilation during general anesthesia is recruitment maneuvers. He stated that they may help to improve and lower incidence of postoperative pulmonary complications. There are some other papers that are more strict and recommend recruitment maneuvers routinely. But also there are some works that are concerned about the complications from providing recruitment maneuvers. But after all, we came to decision to include recruitment maneuvers in our standard, and we recommend to do routine recruitment maneuvers after intubation of the patient and finalizing the position of the patient for the procedure. And this is one of the work showing for me why we should do the routine recruitment maneuvers. And we know that recruitment maneuvers during general anesthesia improve dynamic and static compliance. Also, we know that after intubation in healthy volunteers that undergo a CT scan, there were atelectasis about 30%. So we know that nearly every patient after pre-oxygenation and intubation suffers from atelectasis. And the problem from my point of view is that the general anesthesia or most of the procedures are not that long, and we are not able to recruit the atelectasis just by adding some PEEP and some appropriate volume. Because what we know, the worst outcome for the patients is for the patients with laparoscopy surgery, from the papers I mentioned, who received low PEEP and low volume and were extubated with the atelectasis, and the atelectasis can remain up to 3 weeks. And that's the problem why we don't see the postoperative pulmonary complications, because the complications mostly comes out of the atelectasis that is for a long time after we dismiss the patients from our care. And I hope that I show that postoperative pulmonary complications and lung protective complications, it should be a hot topic, and we should take care about the topic, even though we don't see the patients and consequences immediately in everyday practice. And that led us to a question, if we really care about postoperative pulmonary complications and about this topic. And we found some papers, and worldwide reported in adherence to lung protective ventilation is about 15%. And it really doesn't matter nearly what year of the paper you choose. Last 20 years, 10 to 15% anesthesiologists use lung protective ventilation concept during giving the care. And we found a work that is very recent from Wilson. It's from 2023. And he showed that by staff training, the lung protective, the adherence for lung protective complication can be increased, which should be obvious, but still it's the first work that proved this, and I think that was one of the first work that used structured learning for the staff. So we thought how we can state our adherence to lung protective ventilation in our clinic. All the work that I mentioned about the incident, about the adherence, are based on questionnaires. I think that if you have any expertise or experience with questionnaires, you know there are some several disadvantages of questionnaires, and it's the receiving rate from the questionnaires. It's expected that you have only 20% of respondents to fill in the questionnaires, and also for me, one of the biggest disadvantages is that if you want information about lung protective ventilation during general anesthesia and you want it collect the data with questionnaires, you can predict that the questionnaires will be answered with the most educated physicians. So that's maybe why now I would say in other papers the adherence to lung protective ventilation was that high. I will show you what was our adherence. Which was a bit different. So we choose not to use questionnaires for any data collection. And another problem with questionnaires for this topic is that you give information only about initial setting of the ventilator, but it's very clear that the setting will differ during induction, during maintenance, and during emergence of the anesthesia. So we were looking for some cloud-based solution, ideally, with some automatic data collection, and that was the point where we came across Care Station Insights and its LPV dashboards. It is cloud-based solution, as Peter talked. There is no need for physicians to start the data collection and so on. So it seems like ideal tool for us. I must be fair now, it's still not transferred over the air, so there's always someone who will unplug. But you have to check the connections, and that was the only problem that we came across during our project. And Peter already showed you some windows about LPV dashboard. The most interesting for us was the recruitment maneuvers, because it was a new practice for our team, because these are the data from Ústí. As you can see, we nearly used no recruitment maneuvers at all, and this should be 14. So we have only 14% cases with any recruitment maneuvers, with no specific timing, and the exit PEEP here, it's not a recruitment maneuver, as you may think. It's the only PEEP that is exit after the recruitment maneuver. So if you do the recruitment maneuver and you exit with PEEP 0, then it's clear that the recruitment maneuver is useless because you exit with PEEP 0. So that's only for explanation why only this one is completely blue in our department. So and this is the overview of like standard ventilation measurements, and these are like the very well known ones, so no big surprise in this part of the table. So we make an audit of our adherence to lung protective ventilation. We found very poor results compared to other papers. So we knew that there must be some change in daily practice and to have a better care for our patients. So we started structured data collection with Care Station Insights. Then we developed the standard operating procedure and whole structured educational program for our physicians. I will talk about that later. And after we finish this intervention, we again monitor the adherence to lung protective ventilation. So this is the major ventilation parameters from Ústí. You can see that the tidal volume is in recommended range, the same with driving pressure. There was already a good mean PEEP during the procedures, but still you can use that. Some people used in that time ZEEP, which is totally not recommended, and other parameters were in the recommended range. The other situation was with recruitment maneuvers. As I mentioned, then were nearly done no recruitment maneuvers at all during general anesthesia. So we developed the educational program. We keep our ICEs to one of our halls. We connected our ventilation simulator, and based on the data we have from Care Station Insights, we've prepared several situations and scenarios, and all the physicians can try to solve the scenarios. And the scenarios were based on using recruitment maneuvers, because there were no done at all in daily clinical practice. And we teach our physicians on ventilation simulator how to use the automatic recruitment maneuvers. Thanks to Care Station Insights, we knew that they are not using the recruitment maneuvers, and asking them, we get to know that they are using the squeezing back technique, which is not recommended. So it was another valuable input that we had from the data from Care Station Insights. And we showed them that there's also a PEEP titration tool. And I must say that after this educational program, there were very positive feedback from colleagues, and not just from the younger ones, but also from the older physicians and from senior physicians as well, because they see why we need the change to implement, and that the change is improving the care of the patients, and they found the educational programs very relevant for their practice. And these are the data after the educational program. You can see that slightly moving of higher PEEP, because we set the threshold for 8, but no much of surprise. But there was total improvement in using recruitment maneuvers on the routine, and mainly after induction, because we said that our goal for the first phase is to implement in the recruitment maneuvers after induction, and then keeping the patient with sufficient PEEP to the end. And there was there is a controversy about routine recruitment maneuvers before extubation. So in the first phase, we don't want to implement too many changes at once, so we started with the induction, because we see that more important for patients. And I would like to end my presentation with 2 quotes that I like. One is from Lord Kelvin, and he said that if you can't measure it, you can't improve it, which we prove in our department was totally right. We didn't know about the problem until we measure it, and then we can find the ways how to improve. And the other one is from very famous economist Peter Drucker, and he said if you can measure it, you can manage it. And that's another quote that we can apply to this problematics and to much more problematics than just this one, because we know that we can make a change, but we have to take care of the change to make the change last. So we need continuous monitoring if it's if it's lasting as we want. And we measure it. If we measure now in Ústí, the adherence, this was 4%, was the adherence for the whole bundle of lung protective ventilation recommendations at the beginning, and now we are about 37%. It could be perceived as still very low. Yeah, from my perspective, it could be much better, but if we compare to other papers that measured, still it's doubled. So I would say it's not that bad. And that brings me to a few last words. And let me share some thoughts about the future, maybe, because I think that this is the right place that when we can discuss the future. And I think if we can make a web or some connections to share the data from Care Station Insights or from whatever platform we are using, we can share our expertise and we can compare each other. Maybe we can even make some benchmarks that could be useful for us. That could be the driving force for the change in the field of lung protective ventilation during general anesthesia. Thank you.